So this is the more specific treatment for patients who hurt with lupus. Again, physical therapy and OT, we have an expert here, but it really plays a role across the board. A lot of times patients can't do it because they hurt too much, and it's really up to us to try and design with either aquatherapy or low impact to try and get people to move. This is my personal bias, and is that I think when we use our muscles, if we can, and we move and we exercise, we tend to feel better. It's our role to try and find the exercise, the way of exercising people so they get a little motion. We weren't designed to sit. But sometimes, it's really a problem because of the disability that lupus has done. So sometimes it's a real challenge. Non-steroidal anti-inflammatory drugs are very, very helpful for the aches and pains. But as you may be aware of, there are lots of side effects with these drugs. We use them. We try and use them judiciously. These are drugs like naproxen, naproxen, meloxicam. But patients who have heart disease or high blood pressure or kidney problems, these drugs sometimes can't be used. Most patients have been on steroids. Prednisone, you say lupus, prednisone. It's hard not to treat somebody without prednisone, but the goal is always to treat to the lowest dose possible. And that's the goal, for most rheumatologists, to try and reduce the dose of prednisone. And if you can't, we oftentimes use drugs like hydroxychloroquine. The American College of Rheumatology just released a 2012 approach to treating lupus, and their guidelines. And I would say that this is like a foundation drug. Like if you have lupus, you probably should be on hydroxychloroquine, which goes by the trade name of Plaquenil. You may have heard that. Okay. So hydroxychloroquine, it has many benefits, but it's very, very good for the arthritis, the aches and myalgias, and sometimes the fatigue of lupus. These are very, very good drugs, but these are old drugs. Methotrexate is sort of a standard treatment for rheumatoid arthritis. So if the arthritis pain is really bad and we can't control it, there's a lot of inflammation, this is one of the drugs that most rheumatologists would turn to. I didn't put Imuran down, but Imuran's another choice. We usually use methotrexate because most rheumatologists are more comfortable using methotrexate for the arthritis component. Some of you might recognize this drug, belimumab. This is the first drug that has been designed and approved for lupus. But belimumab was really out for now about a little over a year and a half, I think. And it's an intravenous medication. And it's indicated for patients who have sometimes a lot of the features that we discuss that aren't doing well, that don't have major disease manifestations. And what I mean by major disease manifestations are kidney disease, active kidney disease, active CNS disease, brain or nerve disease, active hematological problems like low platelets. It may be very helpful for skin disease. So this is not, if you have serious, those kinds of major organ involvement, this drug is not at this point indicated. There are ongoing studies. But at this point, we use this drug really for patients for people who have the kinds of complaints that you have that we can't control and are on too much steroid. So the question is, what's too much steroid? And that's something that needs to be discussed individually with you and your doctor. This is an intravenous drug. It's given on a monthly basis after you load the patient up, and it's being looked at for other more serious manifestations. Tocilizumab is a drug that's approved for rheumatoid arthritis. It targets a specific cytokine, a molecule that plays a role in inflammation, and it's being looked at for lupus. But not, that's all being studied right now.